Uh, we now come to a different scenario here that uh, achieving multifocality. What are the various methods? So we have Dr. Shilpa KODKANY who will be now talking to us about multifocalities with monovision. Following this, we'll have Dr. Nikhil Nasta who's filling in for Dr. Vavikar because Dr. Vavikar couldn't be here due to an emergency to talk about multifocality with EDOFs and multifocal IOLs. Shilpa.
At the outset, I thank our chief instructor, Dr. Nitin, for having given me this opportunity. And it's also a great pleasure today because I'm debating with my student, Nikhil. So it's icing over the cake. So, well, multifocality in today's era. So I'm going to talk on monovision. Monovision basically is correction of the distance vision in one eye and the near in the other. So it addresses your correction of presbyopia. And in the past 4 decades or more, we have been doing it in contact lenses, refractive surgeries, and now refractive cataract surgeries. Well, I'm sure all of you here would agree with me that our most happy patients are the ones with monofocal IOLs. So, having said that, we can't leave a patient presbyopic. Like Rupal said, her husband would have killed her if she couldn't give him good near vision. So this definitely is an issue. So monovision concept wherein distance vision is corrected in the dominant eye and near vision in the non-dominant eye. Of course, there is going to be some amount of neuroadaptation, but that is there in all the premium multifocals, trifocals, EDOFs, whatever it may be. Now, there's a very simple way of checking dominance in which it can be done very easily in your OPDs, where you make the patient look not that way, ma'am, this way. Okay, a little further away. And in your vision chart, the first letter is what you, 6 by 60, is what you project. And you close one eye and then the other. So the one in which the object will move is the non-dominant eye. In the eye that it doesn't move is the dominant eye. But of course, there have been problems in the past because monovision used to be emetropia in one eye and almost 2.5 and sometimes even 3 diopters in the other. So this huge amount of anisometropia definitely compromised on stereopsis and contrast sensitivity. And of course, the problem of intermediate vision, because nowadays all of us, we don't care about our distance or our near. Our intermediate is something that is very, very important to us. And that's why multifocals, trifocals, EDOFs, all these came in. But premium IOLs, there are problems. Induced aberrations, dysphotopsias, reduced contrast sensitivity, poor night vision. There is extra time required for neuroadaptation as compared to monovision, and the Z syndrome, of course. EDOFs do reduce these phenomena, but near vision is not satisfactory. So what have we really achieved here? So just like in the past, PRK was there and went out. And then it did a comeback with a little difference where mitomycin was used. We have trans PRK now. And similarly, even Amitabh Bachchan came back with a humongous bang because he changed his strategy. He started acting his age. So similarly, monovision came back with micromonovision, wherein you just make the non-dominant eye about 0.75 to 1 diopter. I normally prefer to make the patient about 0.75 myopic. But I will also tell you how I do it. Well, micromonovision, there is less anisometropia as compared to the earlier monovision. No glare, no halos. Like I said, monofocals are the best lenses even today. We still don't have an answer for our IOLs where we can get good multifocality with no glare, no halos. Otherwise, I myself would have got it done long back. I'm waiting for that lens today. And it's also useful in different ocular comorbidities. Refractive surgery, well, presbyopic correction has these three basic interrelated factors: visual acuity with no glare halos, depth of field, and no dysphotopsias. There have been so many studies being done even earlier with monovision, not micro, where they have shown good results, but there the problem was intermediate vision. Now, the recent studies have also come in where this is a literature search which was done, and it was seen that there was decreased dependence on spectacles, which was 93%, little or no use of spectacles post-operative for computer use, as well as for near vision. So today, the terminology has changed. It has changed from best corrected visual acuity to best spectacle-free vision. So, and with monofocal IOLs, you can also address the issue of astigmatism with a monofocal toric. So there is this whole checklist or an armamentarium of IOLs that we have today, and I'm sure an honest to God opinion would be monofocal IOLs. Because you sleep well, your patient sleeps well, neither of us have coronaries towards the end of our careers. So all are possible. Of course, we do all the armamentarium which is there. I wouldn't say I don't do EDOFs and I don't do multifocals, but yes, patient selections, more chair time, high costs, so more the cost, more the expectations, all these problems being there. And what I do normally is I make my patients slightly myopic. In the dominant eye also, I don't achieve emetropia. I make them slightly, about 0.2 to 0.3 myopic, as you can see in this chart here. And the non-dominant eye is about 0.6 to 0.7 myopic. So this is how I try to achieve it, wherein my patients get about a 6/9 vision with one eye, but binocular, they are 6/6. But of course, when we are planning on micromonovision, it is very important to counsel the patient, just like in what we do in multifocals or trifocals, that the other eye has to be done quickly. That is something which is very, very important. And always, of course, if the cataract is, there is significant difference in the extent of cataract. If that is there, then of course you'll target the more cataractous eye. But otherwise, if it's more or less the same, then I would prefer to treat the dominant eye first and then go in and seeing the results. Of course, we are quite sure of our results today because of good optical biometers. And this is a study which has been done even in the panoptics IOLs, where there have been halos, starburst signs, glare, all these things. Reduced percentage, but look at that percentage of 16%. It is quite phenomenal. So we have done a study in our own center with 100 eyes, 50 patients, wherein we use the monofocal aspheric, and in some cases where astigmatism was there, we use the toric, and we've done it with the lens being constant, that is the Acrosoft IQ. I have no financial interest. This was just a study, and we've seen that most of our patients came up to 6/9 uniocular and 6/6 binocular, and N8 to almost N6 part in most of these cases. So the exclusion criteria for us were ocular comorbidities, significant dry eye symptoms, strabismus, amblyopia, or anything that compromised on binocular single vision. So the advantages being you can give good distance, intermediate, and near vision, but with micro monovision, not the monovision of the past. Reduced reliance on glasses for patients, improved night vision, enhanced contrast sensitivity with our good aspheric IOL designs, and you can also do this in the Indian intraocular lens segments, and it also offers, because of this, cost-effective solutions. This is, which is very, very important if you want to target the whole range of patients that come to you. So I would say yes, multifocality uh, is definitely there. We have EDOFs, but we have also seen patients with EDOF lenses who have, where we earlier thought EDOF will take care of everything. There will be no glare, no halos. But sometimes we do see these patients, in spite of all the ray tracing and everything, if you have the whole armamentarium of diagnostics, then even then we do have those surprises. But with monofocals, those surprises are not there. Like I said, no coronaries, very important. Thank you so much.
Thank you.